In terms of continuing education credits, this webinar is approved for 1 hour of CME credits or 1.2 hours of nursing education credits. If you would like continuing education credits, this is what you will need to do. After the webinar, please complete the brief post-course evaluation, which is a SurveyMonkey evaluation. The link will be sent to your email address, and the link will also be posted at the close of this webinar. Detailed instructions to claim your credit will be sent out to registrants. If you have not registered, an archived version will be available. Also, after the webinar, we will be posting the slides and an email link to all registered participants. We're pleased to introduce our co-sponsors at the Center for Strengthening Youth Prevention Paradigms. Mia, please tell us a little bit about your center.
Great, will do. Thank you so much for that introduction. The SIP Center is really excited to be partnering today with the California STD HIV Prevention Training Center on today's webinar. Just a little bit about our center. The Center for Strengthening Youth Prevention Paradigms, or we call it the SIP Center, is a capacity building assistance provider at the Division of Adolescent and Young Adult Medicine at Children's Hospital Los Angeles. And we provide technical assistance and trainings to communities, agencies, coalitions, systems of care that are working towards addressing the social determinants of health that create health inequities among youth, whether that's through structural changes, cultural competency, or community mobilization. And we exist within the larger division of adolescent and young adult medicine at CHLA, whose many different programs and services work to advance the health and well-being of adolescents, whether that's through healthcare, health promotion, youth development, professional education, advocacy, and research and evaluation, always in response to the needs of young people and their communities. And the SIP Center works closely with these different programs to assist with health communications activities and also in the dissemination of best practices. And it's my pleasure today to introduce today's speaker, who is a physician at our division and a collaborator with SIP Center. Dr. Claudia Borzutzky is an attending staff physician at Children's Hospital Los Angeles in the Division of Adolescent and Young Adult Medicine. She's also an assistant professor of clinical pediatrics at the University of Southern California's Keck School of Medicine and the program director for the Adolescent Medicine Fellowship here at the division. She received her medical degree from the University of California, Los Angeles School of Medicine, followed by a family medicine internship and residency at Harbor UCLA Medical Center, and then Adolescent Medicine Fellowship at Children's Hospital, Los Angeles. Dr. Borzutzky's clinical and research interests include adolescent sexuality and reproductive health care, as well as obesity and fitness. She's a member of the STD subcommittee for the Society of Adolescent Health and Medicine, is a frequent lecturer at speaking engagements related to diverse topics of adolescent health and sexuality, and is an active faculty member for the Physicians for Reproductive Health Adolescent Reproductive and Sexual Health Education Project, a continuing medical education curriculum delivered to providers around the U.S. And we're excited that she's here with us today to talk about issues in adolescent sexual health, vulnerabilities, and opportunities. Thanks, Claudia.
Great. Thank you, Mia. It's really a pleasure to be here. I hope everybody can hear me. We'll get started, and I'll probably go through the slides fairly quickly just so we can hopefully have a few minutes at the end for questions. So goals for today's talk. One is that we'll review adolescent and young adult vulnerabilities and risk factors that skew STI rates to their disadvantage. Two is to understand the essentials of adolescent-friendly health services and the opportunities for excellent care that they afford. And three is to understand the basics of minor consent and confidentiality laws in California. And I apologize if there's listeners from outside of the state, because these laws definitely are state dependent, and I will be focusing a bit on our state laws here. I have no conflicts of interest to disclose, so from that we will get started. So first I just wanted to touch on why I think it's important to have a focus on adolescent health and healthcare provision. And just a little bit before I talk about the first bullet point about my own personal journey with adolescent medicine, I started taking care of teenagers really as a volunteer when I was in college, and I was very intimidated at first when I was interacting with teens who I thought were probably more sophisticated than I was in a lot of ways, and then I realized they really were just desperate for an adult who would talk honestly and provide information that they could use to make informed choices for themselves, and I really kind of fell in love with the population. It also felt really an impactful way to provide health care because it's such a time of change. So on that note, some of the reasons that I think are good to focus on this age group is that you really can form lifelong habits for health at this time of life that could be positive or negative. And it's really a window in which we have a chance to intervene and provide good change, help facilitate good change. It's also a really exciting time of rapid change and growth physically, developmentally, emotionally, and both youth themselves and their families can really benefit from extra support during this time. And it's really an opportunity to fulfill adolescents' overlooked needs for all kinds of health care, but especially reproductive health care, to which there's often a lot of barriers. And for anybody who's interested in being an advocate and working with the underserved, this is really a wonderful, wonderful opportunity and population to be able to advocate for. So we're going to start with a quiz question. So this will be an audience poll, and you can answer in a moment. So at what average age do U.S. females first have vaginal intercourse? So the choices that you have are 14.2 years, 15.5 years, 16.3 years, and 17.1 years. And go ahead and enter your choice here, and we will have the answer to this question a few slides ahead. Just waiting for everybody to put their answers in. Let's see how everybody does. And by the way, this information comes from the National Survey for Family Growth, which was conducted most recently between 2006 and 2010 that we have data for. All right, looks like we're almost there. Okay, poll's been closed. So it looks like most people chose 15.5, followed by 14.2, then 16.3, and then 17.1. Okay, so we'll have the answer in a moment. All right. So a couple general broad strokes about adolescence before we get to the answer to the poll. You know, adolescents are a really special population in that they're, from a sort of biomedical standpoint, quite healthy. The levels of morbidity are pretty low in adolescents overall, and they're really resilient. They're really able to bounce back from lots of different things, and they're kind of at this interesting transition phase where they're much more independent than they were as young children, but still vulnerable for lots of different reasons that we're going to discuss. And they're really neither, you know, big children nor little adults. They're really their own category. The culture of adolescence, as we all know, there's a lot of dependence on peers and peer opinions. People tend to really be focusing kind of on themselves at this time of life. Adolescents tend to have a distinct sort of language and dress. And one thing that we always talk about with trainees here is that as much as we want teens to be able to feel like they can talk with us and relate to us, they're really not looking for a peer in their medical provider. So it doesn't mean that you have to talk like them or dress like them to be able to be a good provider, but just to be honest and open and sensitive to their needs. Lots of influence from popular culture. I'm always way behind the curve compared to my patients and learn stuff from them all the time about what's going on in the world. And it's really a time where there's sort of ongoing search for identity, trying to figure out who am I? Who am I going to be? So we divide adolescence into three phases roughly. The first phase is early adolescence and generally tends to go from around age 11 to 14. This is when kids are having their growth spurt. Puberty is started and they're starting to develop some of their secondary sexual characteristics physically. They are starting to be able to think a little bit more abstractly than they could as children, sort of being able to think ahead a bit and put themselves in other people's shoes, although still that's a cognitive development that takes through all of adolescence. Middle adolescence, we think of around age 15 to 17. That's a fun-loving group here. So those pubertal changes are starting to complete. They're starting to develop a little bit stronger sense of themselves and relating even more strongly to their peer groups, so sort of separating more from their families. They do become more reflective, as we know. That sort of torturous time of junior high when people are not so nice to each other starts to resolve a little bit at this age group and kids can really think a little bit more about how the impact of their actions are going to affect other people. And then late adolescence is 18 and older, and when does adolescence end is sort of a historical question that changes with time, and we all try to answer it. But we think now that most cognitive changes and the frontal lobe and other parts of the brain start to wrap up around age 25, but that's a moving target. And adolescence is really a culturally defined phenomenon anyway. So in late adolescence, the body really continues to develop, sort of do its final changes and take its adult form. And at this point, young people really are able to now separate even a little bit from their friends and say, I love you as my friend and you're really important to me, but I also have different opinions from you, whereas that's a little harder for younger teens to do. And this is really also a time when people's sexual identity is being generated and formed. So this is a time when we see a lot of people, kind of figuring out what's going on with their sexual orientation and other ways that they express themselves. So sexuality in adolescence, I always like to remind trainees, patients, their parents that, sexuality is normal. It's a completely normal part of adolescence and human development. But it's expressed in different ways and different times for individuals, and that can be mediated, by family, by culture, by religion, all kinds of different reasons, biology, when did puberty happen. But it is important for us to keep in mind as providers that more than 50% of U.S. adolescents have had sex by the time they reach the age of 18. So here's the answer to our first quiz question. The average age of first vaginal intercourse, and this is specifying heterosexual intercourse, for males is 17.1 years, and for females is also 17.1 years. And I think this comes as a surprise to probably most of the audience because this was the least popular answer. And I have a feeling, I suspect that's because many of us in the audience and myself work with higher risk youth. That's who tends to come in to see us, and they've been having sex for longer. But the average age around the country is about 17 years of age. So, and that corresponds as well. We'll be seeing some data from the National Youth Risk Behavior Surveys, which survey teenagers in school about every other year, and this matches up pretty well to the responses that they have gotten most recently for the YRBS. Okay, so moving forward from that, knowing when young people tend to become sexually active, part of why we're talking about this subject today for the Prevention Training Center is that even though 15 to 24-year-olds represent only about a quarter of the sexually active population, they account for nearly half of the new STIs diagnosed in the United States every year. So really, really shouldering the burden in a disproportionate way for their age. Here's a nice bar graph that the CDC published in 2013 that really shows this pictorially. It's not to scale because, as you can see, HPV really dominates as the most incident STI in the United States, much, much more than any of the others. But the big preponderance of those new HPV infections, new chlamydia infections, new gonorrhea infections, and also genital herpes is in young people, much greater than their proportion of the sexually active population. So part of our job is to figure out why that is and what we can do about it. So here is some of the statistics we can see for our state in California. This is for chlamydia in 2013, and you can see that the biggest age groups that are impacted by chlamydia in California are those age groups reflected in that other bar graph between the ages of 15 and 24. And still the lines are very small, but we do unfortunately also have infections in 10 to 14-year-olds as well. You can see the same sorts of representation here with gonorrhea, although it's a little different, especially for the 20 to 24-year-olds. You can see it's more common in men than in women, which is really different from chlamydia diagnoses, and is skewed a little bit older for gonorrhea than chlamydia, but again, we do still have some representation among our really young teens. The other thing to keep in mind is that STIs do not affect all ethnic and racial groups equally, and you can see here it's really staggering among young Black females how much higher the rates of gonorrhea were in 2013, and it's been the same for quite a number of years, than in the other ethnic groups. And there's lots of reasons for that probably, and some of them may be biological and some of them may be social, but probably a lot of them have to do with sort of institutional barriers to care that hopefully we can continue working on. So quiz question number 2. Okay, so here's another audience poll question. What percentage of U.S. teenagers used condoms at their last sexual intercourse in 2013? 48%, 53%, 59%, and 64%. And this is according to the YRBS, the Youth Risk Behavior Survey for 2013. So we'll see what people think. Looks like so far we're about evenly split between 48% and 53%. A little more for 48. We'll be closing the poll in just a moment. All right. Okay, so we'll have the answer to that question a few slides ahead. One sec for that to close. So going back to what I was talking about in terms of the incidence of STIs in young people, what we really want to think about is why. Why are they so disproportionately affected? And as I suggested, there's a number of reasons we think that explain this, and I'm going to go through them a little bit here. So biological risk factors, first of all, for females who tend in the adolescent age group to be much more, to have diagnosed much higher than males for, at least for cervicitis, well, obviously for cervicitis, but for chlamydia and gonorrhea infections that are uncomplicated in adolescents, females have much higher rates of diagnosis than males. So one is that the adolescent cervix itself is more biologically vulnerable than in an older woman. There's still that exposed transition zone at the squamo-columnar junction, and that may make younger females more vulnerable to infection. Another is that they just haven't been exposed before, so have lower levels of local immunity. There's a smaller introitus, which and also often lack of lubrication because of rushed sex or hidden sex or different things like that. And this can lead to sort of dry, more traumatic sex, which can lead to microabrasions, and that may also facilitate the entry of different bacterial or viral pathogens. Cognitive risk factors we think about a lot, and it's hard to generalize with this, but certainly in early adolescence we see more concrete thinking than later. So it's harder to plan ahead. People think that this won't happen to them. It's very difficult for them to judge the risk of getting an STI or that their partner would have an STI, and it's really more, thinking that this is something that happens to other people. And then we have behavioral risk factors. So number 1 is older partners. Sorry, I'm going to go back a slide because I think something got cut out, but that's okay. So older partners can be a problem sometimes because it sort of naturally predisposes couples to a power imbalance, and it can make it much harder for the younger partner to negotiate around sexual issues, such as having sex at all to begin with, using protection, finding out what their partner's history is. Just getting more information can be a lot harder for a developmentally more naive or younger partner. So we see that younger partners that have a significant difference of age with their partner have higher risks for STIs. Here is another behavioral risk factor, and that's condom disuse. So the answer to our second quiz question is in this graph here. This is also from the National Youth Risk Behavior Survey. Uh-oh. The graph is not showing. I don't know what's happening here, but the rate of condom use, I can tell about it, has sort of gone up since the early 1990s when the AIDS epidemic really started to impact the general population in terms of education and intervention. and peaked a few years ago. It's been going down a little bit since then, but it's now at the last check with the YRBS, the percentage of high school students who used a condom and during their last sexual intercourse who were sexually active was about 59%. So it was on the higher end of those options that you had. I'm going to go back to that for a moment so you can see what the options were. And sorry, I will tell you, so it was answer C here was the correct answer to the percent of U.S. teenagers who used condoms at their last sexual intercourse. So I apologize for our technical difficulties with showing the graphs. It looks like it might be happening in some of our other slides as well. So let me get there. The next graph was meant to show behavioral risk factor for substance abuse, and the YRBS asks respondents, and these you have to keep in mind are kids who are actually enrolled in school and going to high school, so they are among the, probably slightly less higher risk young people. The most high-risk young people are probably not in school at all, but the percentage of high school students who reported that they drank alcohol or used drugs before their last sexual intercourse, if I'm not mistaken, was around 22% total. And it varies with age a little bit. It tends to go up with age and varies a little bit among ethnic groups, but it was ranging around 20 to 25% for most groups. So another risk factor that increases the risk of STIs for young people is having multiple partners. So the YRBS also asked, among those who are sexually active, how many of them had already had 4 or more partners in their life. It doesn't specify whether their partners were the same gender as them or not. But the respondents overall said that 15%, so this is of 9th to 12th graders, responded that they had had sex with 4 or more partners during their life. And by the time they got to 12th grade, the percent was about 25%. I'm sorry you can't see the graph here, and we will be sending it out to you. But so it goes up with age, but that's quite a lot if you think about a 17 or 18-year-old. 25% of them have already had sex with 4 people in their lifetime. So of those who were sexually active. And multiple partners is probably the biggest risk factor we see for acquisition of STIs. Social risk factors tend to be a factor as well, and that is the concept there is that epidemiologically STIs tend to pool in social networks. And this report here is from the Los Angeles County Department of Public Health and is organized by race, but I put it here because teens and young people do tend to aggregate socially by race, and you can see how different the rates of different STIs. This one is for chlamydia, and the next one you'll see is for gonorrhea, depending on the racial group. Much higher here for African American young people, and even more so for gonorrhea. Societal risk factors. So I want to spend a little bit more time here on this slide. So for our young people, things that we know that are really about the bigger society that are barriers and increase young people's risk for STIs. Number one is lack of comprehensive sexual education regarding risk and symptoms of STIs. And of course, this has become a very politicized issue and depends on the school district and all different kinds of things, but it's been proven again and again that comprehensive sexual education decreases people's risk relative to abstinence-only education. Lack of insurance and finances to pay for care is a huge factor for teenagers. If it's not something they want to be going to get taken care of with a family member, which is often the case, they're unsure of what their insurance coverage will be if they have insurance or not. How much of it would cost, so that can be a major barrier. Lack of transportation, it's a very practical thing, but especially in not urban places where public transportation is thin and places are far apart, that can be a huge barrier to care for teenagers. And a big one that we'll talk about a little bit more in this talk is concerns about confidentiality. And again, in smaller towns, we're so lucky here in Los Angeles, there's hundreds of places where people can go for health care, and it's pretty easy to be anonymous. But if you live in a small town where there's 1 or 2 medical clinics, it's very likely that the person working at the front desk knows your parents or, is related to you, and confidentiality becomes a much bigger concern in that context. Stigma. teenagers and young people are very worried about what the impact on their personal identity and how people view them will be if they come in for reproductive concerns or sexual health concerns. And all of this leads to adolescents not being screened and treated for STIs. So highlighting confidentiality, we're going to come to that in a little bit, how I recommend that confidentiality be handled in reproductive health visits with adolescents. Before we do that, I wanted to talk about some of the protective factors that we see that really help reduce risk for teenagers, because those are things we also really want to help promote and support. So one is peer support. If people know that their friends use contraception and use condoms and talk about them positively, that's going to influence them in a positive way and predispose them much more to go ahead and seek those items, whether it's hormonal contraception or condoms, which will protect them from STIs. Another is communication with their parents about sex. This doesn't mean that the parents have to be telling them sex is good and you should use condoms, but just communication at all about sex and what parental values are about sex. That sometimes parents are willing to talk about their own histories or what they think is the right thing or the wrong thing based on their religion or their culture, but just having open discussions about that really, really helps teenagers feel confident about seeking services for themselves. A connection to their family has been shown to be a protective factor for STIs, connection to community organizations, and along that line, future goals. So the model of positive youth development really has been founded in this idea that if people can see their future and can see themselves as a successful person later on in life, that's a much bigger motivation to stop and take a moment to protect themselves, but potentially change the decision about the behavior they're about to engage in than just somebody telling them you shouldn't do this because it's bad for you. So having plans, thinking I'm going to go to college, I'm going to have a particular kind of job, I want to be a particular kind of parent. These are the sort of visions that people have that are really going to impact the minute-to-minute decisions they make much more than anything else. And so, of course, just supporting our youth development in general is going to be the best way to reduce rates of different sexual risks. Okay, so quiz question number 3. What was the percent change in the teen birth rate between 1991 and 2013? The choices here are, did it increase by 13% in those 27 years? Was there no change? Did it decrease by 13%, decrease by 28%, or decrease by 57%? And these statistics, the answer comes from the National Center for Health Statistics. So it looks like we have mostly people voting for 28% decrease. Looks like we have a bunch of votes in, and we will close the poll in a moment. We're going to adjust the volume here, and hopefully you'll be able to hear me better. Let us know if that works better. All right, the poll is closed, and we'll get the answer to this one very quickly here. One moment. Looks like most people voted for 28% decrease in the teen birth rate. Just a sec. All right. So, let me see. Ashley or Sharon, my slides are not advancing. Let's see if there's another way we can do it. Oh, there we go. Okay, so good news. So the answer was not an increase and it was not 0. The birth rate for U.S. teenagers in 2013 fell to the lowest rate ever reported since it started to be recorded, and fell for both younger and older teens. So you can see here it's really dramatic decreases. Now this graph shows from starting in the 1960s when, of course, there were a lot more young moms, especially in that 18 to 19-year-old group who tended to get married young. But you can see here that there's been a huge decrease since the second bump, which happened in the early 1990s. More good news is not only did the decreases occur in all age groups for teenagers, but it occurred in all ethnic groups as well. And you can see in this nice graph here, the dotted black line is all teenagers, all groups between age 15 to 19. So there's been a drop in 1991 from 60 per 1,000 females having a live birth down to around 25 or so in 2012 on this graph. And you can see how dramatic the drop has been for African American girls, which is the green line, for Native American girls, which is the purple line, and then orange is Latina. So this drop has been seen in all ethnic groups and has continued. This graph only goes to 2012, but it continued to drop in both 2013 and 2014. So the answer to the question was the highest number there was 57% has been the drop. Why? Why has it dropped so much? So we have a wonderful analysis that was done. It's now a little bit aged. It's back in 2007 was published by John Santelli, who's a public health researcher at Columbia. He and his group looked at the National Survey for Family Growth to try to determine what had caused the decline in those years, because by 2006 there were big drops that had already been seen. Whoops, So it looks like the graphic is not here, but what their analysis showed was that 86% of the decline in teen birth rates was attributable to bigger use of birth control, so greater use of contraception, and only 14% was due to a decrease in sexual activity. So this is a little bit of a response to that political, sort of concept that we just need to tell people to say no and that abstinence is going to be the cure for this, but actually the huge preponderance of that birth rate was shown to be due to greater uses of birth control. So one of those greater uses of contraception has to do with emergency contraception, and you can see here some of the great messages that have been put out there about EC. But bigger and more better prepared teens and young people around emergency contraception has been responsible in part for that decrease in the birth rate. The other thing has been the slow but steady increase in the use of long-acting reversible contraceptives. So those include subcutaneous implants. The only one we have right now on the market here goes by the brand name Nexplanon, and it's an etonogestrel or progestin-only contraceptive that lasts 3 years, and then intrauterine contraceptives, of which we have various, one being very old and being around for a long time, and that's the Paragard Copper T, which lasts for 10 to 12 years, and then we have hormonal intrauterine contraceptives, including Mirena and Skyla, and just recently a new IUD called Liletta has just been approved by the FDA. Unfortunately, though, even with those great declines, it's not all good news. When we compare the U.S. against our developed peers, mostly here in Europe, you can see if we were on this graph, we would be way up at the top in between, I think, the U.K. and Slovakia, or between Slovakia and Romania. We would be around 29th in this ranking for our teen birth rate. And when you look at the teen pregnancy rate, it's even higher compared. In Switzerland in 2011, there were 8 teen pregnancies per 1,000 girls, and here in the U.S. there were 57, most of which, of course, were unintended. Why? Well, one thing is the MMWR came out with a report about a year ago showing that the great proportion of sexually active teens reported that they did have sex ed, but not until after they had already become sexually active. So again, the more we could be doing to provide comprehensive sexual education, in all likelihood, the better our outcomes would be. So what can we as clinicians, medical providers, do to help? So one is to provide adolescent-friendly health services, and we'll talk a little bit about that. Another is to respect the minor consent and confidentiality laws that exist in our state. And 3, of course, is to do appropriate screening and treatment. So adolescent-friendly health services essentials. If it's possible, an adolescent-specific setting is ideal. At least even if you can have a separate waiting room or an afternoon or a morning where you see teens and young people, that can make it a lot more comfortable for those patients to come in when they see people that kind of look like them around them in the waiting room. Having displays, training peer educators that are focused on young people is also ideal. having a comfortable, confidential, and safe space. So again, that confidentiality part is very, very important for teens and young adults to feel comfortable accessing services around sexual health. Adolescent-friendly office staff and providers. So of course, if you have someone at the front desk, the first person who greets the patient, if they don't like teenagers and it shows, well, that's not going to be a very nice place for the person to come, even if the clinicians are wonderful. So we want to train and orient all of our staff from their first interaction to the last one to be accommodating and friendly to our young people. Financial affordability, flexible scheduling, and comprehensive services are highly recommended for the reasons that we've already discussed. Assistance with registration for available resources such as Family Pact, which is an insurance program we have here in California for reproductive health issues, and for minors in particular, they can register for Family Pact even if they have other insurance, if they have concerns about confidentiality with their other insurance. Services for patients transitioning to the adult healthcare system, especially for those of you out there that, like us, work with young people with chronic medical conditions. Assisting them in the transition to the adult healthcare system is so essential because many times they really get lost in that transition when there's not a good handoff. And for those of our patients who are really accustomed to getting their medical care in the pediatric world, it's kind of a cold, hard reality when they get to the adult world how different it is, and whatever that we can do to support that transition so they don't have big gaps in their care is really important. And then lastly, sensitivity, of course, to how ability, age, culture, gender identity, sexual orientation, religion, and socioeconomic status can affect an adolescent's reproductive health. Because as we've discussed, all of these things can factor into how the individual might have acquired, a risk or an actual STD, risk for STD, and then their ability to access care for it. So we really, really recommend that there be an advanced discussion of confidentiality, both with patients and if you're in a more family-based setting with their parents. It can be very, very helpful to let parents know before the visit about confidentiality policies. Some offices will send a letter home if it's a pediatric office or a family practice where they see the whole age spectrum. It's a change, obviously, for parents if, for their children, they were always in the room, and then all of a sudden at age 11 or 12, they're being asked to leave. And although most of our parents are cooperative with that and understand when we explain why, it can be really helpful for them to have some preparation for that in advance. So a letter home can detail when the parent will be included in the visit and when not, and could also discuss billing issues that the parents may actually receive bills for services that they did not know were going to happen, and that's because their kid could consent to them. Displaying materials such as posters or brochures, and I'll show some of those, discussing the importance of doctor-patient confidentiality is also really helpful, just normalizes it for everybody who walks by. And then really importantly, explaining confidentiality rules to youth prior to taking their history. So I'll talk about that in a moment. So here's an example from the Adolescent Health Working Group Provider Toolkit, and I'll put up their website at the end. It's a wonderful, wonderful resource that has really comprehensive recommendations and guidelines for people working with teenagers. So you can see here a note to parents from your teen's doctor, and it has some guidelines here about how we view teens and their need for confidential care. I'm not going to read that. You can read it yourself. And these will be posted as well. Here's a sign that we have posted in some of our exam rooms here, the truth about confidentiality. And again, this is California specific because this refers to our confidentiality laws here. But this reviews what we can or cannot disclose to anybody based on the kind of information it is, and then related to sexual activity and age differences, which I'll talk about as well. And in the box, confidentiality tips for teens. You can ask about confidentiality. You can ask your provider, know what your rights are in the healthcare system, which of course most teens do not. So the more we can share with them about that, the better. And then of course, we always recommend people to read and understand forms before they sign them. Doesn't always happen, but here's another poster from the Adolescent Health Working Group Provider Toolkit that you can post in your exam rooms or your lobbies, and these are all really helpful. So what are the basics of consent and confidentiality in California? Really, really important to know about. here's our last quiz question. So at what age can minors consent to STI services in California? So we'll have our last audience poll here. Option number 1, minors of any age can consent to STI services. Number 2, they have to be 12 and above. Number 3, 16 and above. And number 4, minors cannot consent. You must be 18 years old. So let's see how this one settles out here. Looks like most people are choosing option 2, minors 12 years and above. We have a few who are saying any age, a few who are saying 16 and older, and nobody's choosing 18. All right, so we're going to close this poll in just a moment. Thank you for your votes. All right. So we get our answer right away on this one. So this is a very helpful, handy chart, which you can also find at the Adolescent Health Working Group website or at teenhealthlaw.org, which I'll show in a moment. And you can see here, right in the middle of the upper part of this chart, that most of you were absolutely correct. Minors 12 years and older in California can consent to services for STDs. It's a little different for services around pregnancy, anything pregnancy related in California. Minors of any age can consent to services, but for STDs, it's 12 years and older. And it's important to keep in mind that every one of these boxes really has been legislated separately in the California legislature, and it's not always obvious what the logic was to some of the differences. And not being an attorney, I can't always explain them all. But you can see here there's some subtle differences between for substance abuse, depending on who funds the treatment, and rape versus sexual assault is different, and how that's defined is not so clear in the law. But for STDs, it's pretty clear. Minors 12 years and older can consent to diagnostic services and treatment without parental consent. And in fact, parents cannot consent for their kids or against the wishes of their kids, and we are not allowed to notify parents without explicit consent of the minor about services for STDs. And there will be hopefully time for questions about this if you have any. We have a couple new laws in the last 5 years that sort of added to this and update this chart. In 2011, Assembly Bill 499 added prevention of STIs to the list of services that minors 12 years or older could consent to. So not just diagnosis and treatment, but also prevention. So that means, to the surprise of many parents, that their 12 years old and older minors can consent to vaccination for HPV or hepatitis B. And of course, that's not always practically easy to do if you have a parent and a child together and the parent has said no and the child has said yes, but there are ways we can try to orchestrate that. Since these vaccines are covered by Vaccines for Children, we can bring patients in for confidential services for those alone if possible for them to get those vaccines. Of course, it's always better to get the parents on board. We do our best to do that, but by the law, minors 12 years and older can actually consent to those vaccines. And the other thing just to know, which is an update to this chart, not about reproductive health care, but State Assembly Bill 543, same year, 2011, also changed the consent law around mental health treatment. In the past, before that, minors who were 12 years and older could consent to their own mental health treatment, but only if they were gravely, gravely impaired and ill and about to commit suicide or homicide or hurt somebody else. And that law changed it so that it didn't have to be so grave. They could consent to mental health services before things got that bad. So that's also a great addition to the law. That does not apply to psychotropic medications, by the way. For medications, parental consent is still required. But for psychotherapeutic services, minors can consent even if they're not gravely, gravely ill. So the last few slides I wanted to review briefly about what we want to ask and what we have to tell and what we don't. So the first thing is, what am I mandated to ask? And this is kind of the source of a lot of confusion for a lot of providers. The next thing is not so much what am I mandated to ask by the law, but what should I ask to provide good clinical care? And then the last thing is, what am I mandated to report? What am I mandated by the law as a medical provider to report? So for the first question, what am I mandated to ask? If I'm discussing sexual intercourse with a minor, are there questions I have to ask that minor? And the answer is no. There's nothing that I have to ask anybody. So I can use my clinical judgment to decide what questions to ask, regardless of the age of my patient telling me that they've been sexually active. What should I ask is another story, because of course we want to get as much information as we can to be able to support and treat and screen our patients properly. So we advocate for the use of the HEADS exam, which is an acronym that some of you may be familiar with. It's very popular and used in adolescent medicine and hopefully in pediatrics, and is a mnemonic that helps remember key questions to ask adolescents in a particular order that facilitates developing some rapport quickly with them. So I'm going to go through that. And the HEADS exam really helps you find out what the strengths are of your patient and also what some of their risks may be. The HEADS exam, I just want to point out, can take as long as you give it. You can spend an hour with a patient doing a HEADS exam, or you can make it much shorter and make it 5 minutes, and it really depends, you know, on your setting and what's practical and how worried you are about that particular patient, how much you want to ask them. It's also been adjusted, and people have added in letters and D's and S's, but I'm going to give you a basic framework for the HEADS exam here. So before I start with home, back to the issue about confidentiality, I always sort of give patients a preamble and say, you know, I'm going to ask you a bunch of questions. They're all really kind of personal. You do not have to answer anything that you don't want to answer. And then I review the limits of confidentiality with them. So in California, I tell them, you know, as a minor, you have a right to confidential health care around issues that have to do with relationships, sex, drugs, your mood. And that means that I cannot share any of your answers with anybody, including your parents or teachers or anybody else, without your permission. And then I go on to say, but there are some exceptions to that, which are that if you tell me that someone has hurt you in any way at any point in time, that you might hurt yourself or that you might hurt another person, those are things I'm not allowed to keep to myself. And it's not necessarily even that I would tell your parents, but those are things that I have to get help for. I'm not allowed to keep to myself. So that sort of establishes some boundaries for them, and they can have a context in which to know what, you know, they feel comfortable sharing and what they don't. So the HEADS exam starts with H for home. So I might ask, who do you live with? Where do you live? Do you have other relatives with you besides your mom? Do you have siblings? Any extended family? Any friends of the family? Do you feel safe at home? Do you feel safe in your neighborhood? Pretty, you know, sort of straightforward questions. Education, where do you go to school? What grade are you in? How do you like school? What are your grades? You know, if someone tells me my grades are okay, and I say, really, what does that mean for you? Because lots of times people say their grades are fine, and they say my grades are C's and D's and F's. Well, that's a really big red flag, because school is really the full-time occupation of most teenagers, and if they're not doing well in school, that's a really big, you know, warning sign that things, there's some kind of dysfunction, things are not going well in general. So I might ask what they want to do after school, what they see for their career, etc. Activities, what do you like to do for fun? So this is really important, gives you a little window into their life. I also try to ask a little bit about digital media use here, and sometimes if I'm worried for whatever reason, I might ask about, you know, in the context of sexual health stuff, how much they are using media for sort of sexual interactions, and talk about their digital footprint and all that good stuff. But the most important thing in activities here really is there things they like to do, or are there things they enjoy, and do they have friends? Because if they tell me the only things I really like to do, which I've heard before, is sleep and watch TV, you know, again, those are really big red flags that this person is really isolated and possibly depressed. And if they don't have friends, again, that's a really big function of teenage life, and that's a real concern. Diet and exercise is D. So for someone who's a normal weight, I might spend a little less time inquiring about this, but anybody whose weight is really high or really low, I'm going to get into the details more with them about these questions. Next is drugs and alcohol. So you can see as we go through the HEADS exam, the sort of sensitivity level of these questions and the stakes confidentiality-wise are increasing. But hopefully with those first few questions that felt less personal about where do you live and where do you go to school and what do you like to do for fun, you've developed a little mini rapport with the patient quickly, and they will hopefully feel more comfortable answering these questions than if you had asked them right at the start. So the next questions are about drugs and alcohol. Then we get to suicide and depression. Then we get to sexual activity, which we're going to focus on here. And lastly, safety. So for sexual activity and a sexual history, you may have heard from the CDC, they recommend the 5 Ps, but I always add on a 6th one for teenager, and that's the first one here, which is presentation. So when did they first have sex? If their age of onset of sexual activity is 2, standards of deviation lower than the average, which was 17, so if they tell me they were 13 or 14 years old when they first had sex, that's going to put up a little, my radar a little bit to inquire a little more about it. Was it consensual? How was that experience for them? Because the younger they were when they first started having sex, the more partners they've had, the more risks they have for STIs and pregnancy and other problems. The next P is their partners. So genders of their partners, number of their partners in their lifetime, and then current would be in the last 3 months or so. Prevention of pregnancy, so if they're in a heterosexual sexual relationship, then what are they doing for prevention of pregnancy? Do they know about different forms of contraception? Do they know about EC? What are they doing to protect themselves from STIs? What % condom use have they had in their lifetime in the last 3 months with most of their relationships? What are their sexual practices? Types of sex they have, whether it was receptive or insertive, and then their past history of STIs. We just have a couple minutes left, so I'm going to speed through the last few slides here. What am I mandated to report as child abuse? So in California, healthcare practitioners are mandated to report any reasonable suspicion of child abuse. So if my patient is 13 or 14, even if I don't know the age of their partner, if I suspect that there was coercion involved in their sexual activity, then I have to report that. It doesn't matter who their partner was or how old. If I am suspicious there was coercion or abuse, then I must report it. So, and their partner could be the same age or younger than them. It doesn't matter. Then there's this very complicated grid, which most of us have to look at every time, so don't feel bad if it looks overwhelming, but this is based on the age difference between the partner and the patient. And so the orange here is when we're mandated, and the vertical column is the age of our patient. So if we have a patient who's 14 years old and you go across and their partner is 13 years old, is younger than them, there's an M there. That means you're mandated to report that, even if they say it was completely consensual. Any of the area on this grid that says CJ, that's clinical judgment. You're allowed to use your clinical judgment to determine if it needs to be reported. But if your patient was 15 and their partner was 21, that's, again, a mandated report. So for the youngest patients, we're mandated to report. If they're 13 and they have a partner that's older than them at all, 14 or older. And then for our 14 and 15-year-olds, if their partner is 21 years or older, we're mandated to report. And in most cases, the Department of Children and Family Services, if we say this was completely consensual, I really don't have concerns that there was abuse here, but I'm reporting because I have to, in most cases the report's going to get filed, and depending on how busy your department is in your county, probably not a lot is going to happen with it. This is different from statutory rape, and that's a whole other lecture, and that has to do with parental concerns and pursuing legal action when someone was under 18 and someone was over 18. But this is our duties as child abuse reporters, and this can be seen at teenhealthlaw.org. So, but just remember, even that said, your patients who are 12 years and older, regardless of the age of their partner, can still consent to their own services around possible pregnancy or STDs and prevention of both. So we have a few short minutes left for questions. I'd be happy to take any questions, and here you can see the resources that I referred to during the talk, which you can visit anytime. So I think there's an area you can type in if you have any questions for us. We'd be happy to take them.
Yes, Claudia, thank you so much for this very informative presentation. We received a few questions, and we'll get to what we can get to, but we'll be sending out questions that you don't have time to respond to all registrants. The first question that we got was, what year or age do they start sex ed in school?
Right. Well, I think that's completely dependent on your school district. For us in Los Angeles, in the public schools, 5th grade, I think, is when there's first some reproductive, like sex ed in health education, and then I believe it gets repeated like in 7th and 10th grade. But that completely depends on where you live. And in more conservative school districts, sometimes they don't get it at all because it's not mandated. You know, there's some funding issues, I think, from the federal government. Schools get more or less, if I'm not mistaken, depending on if they provide sex ed or not, but that's up to the district whether they want to use those funds or not. And don't quote me about that, but it really depends on where you live. Any other questions, Sharon, that we can cover in the last minute?
Yes, we have a question. Do we know why the pregnancy rates, let's see, I'm trying to get the whole question here. 1 second. Do we know why the pregnancy rates are so low in Switzerland?
That's a great question. But one thing that we know is that in some of the European countries, there's just a much more open attitude about talking about adolescent sexuality in general. It's just not as sort of covert and closeted as here. In fact, in Holland, there's been a lot of research kind of comparing. There's a scholar named Amy Shallett who lives here in the United States, but she's compared Holland and the United States, and it's very interesting. Parents in Holland are much more likely to say, well, you know, they're in a relationship. I'd way rather them have sex here at my house where it's safe and have a sleepover here than be out parked somewhere or who knows where. And that attitude is so different from parents' attitudes here in the United States, where they'll say, well, it might be happening, but it can't happen under my roof. I couldn't possibly sanction that. And so that's part of it. It's just that the societies are more open about it, and that it makes it easier to promote sex education and contraception, and it's okay to carry a condom with you, and a whole bunch of things that here in our society are just really taboo. So that's what we think is part of it. And there's probably also a lot more governmental support for services, and there's universal health care in a lot of the European nations as well.
Well, thank you so much, Claudia, and thank you to everyone who's attended. We did receive a bunch of other questions, and we will send answers to those questions out along with the recorded webinar, as well as your evaluation and information on how to get continuing education credits. Thank you so much again for attending the webinar, and we will be having future STD expert webinars sent out as well. Thank you, Claudia.
Thanks. Goodbye.
Bye-bye.